This is the second comic for the European Society of Endocrinology and Endocrine Society Joint Clinical Guidelines for Glucocorticoid-induced adrenal insufficiency. This video will summarize clinical questions, recommendations for glucocorticoid therapy in non-endocrine conditions, and tips for patient education on glucocorticoid use. Clinical question 1 looked at the incidence of recovery of HPA axis function in patients with glucocorticoid-induced adrenal insufficiency. The number of patients with recovery of HPA axis was divided by the total number of patients with glucocorticoid-induced adrenal insufficiency. 4 weeks after stopping short-term high-dose glucocorticoid therapy, the rate of adrenal insufficiency decreased from 38.7% to 14.9%. 6 months after stopping long-term medium-dose glucocorticoid therapy, the rate of adrenal insufficiency dropped from 56.4% to 25.3%. Clinical sub-question 1a examined which clinical and biochemical factors predict recovery of HPA axis function in patients with glucocorticoid-induced adrenal insufficiency. In the first study, patients recovering adrenal function had higher cortisol increments during the first ACTH test than patients without recovery. The next study found that patients recovering adrenal function had higher morning cortisol values between ACTH tests compared to those who did not recover. Clinical question 2 looked at the best tapering strategy for patients not requiring glucocorticoid treatment. It is safe to stop glucocorticoids completely after short-term use. After long-term use, it is best to do rapid tapering followed by slower tapering after. Clinical question 3 compared the accuracy of morning cortisol levels with the ACTH stimulation test in diagnosing glucocorticoid-induced adrenal insufficiency. Depending on the cortisol measurement method, the 3 studies showed that most patients with morning cortisol levels less than 100 to 124 nanomoles per litre failed the ACTH test. Conversely, most patients with morning cortisol levels higher than 300 to 350 nanomoles per litre passed the test. Now we will discuss the recommendations from the guideline. In patients on or tapering off glucocorticoid therapy for non-endocrine conditions, evaluation by an endocrinology specialist is usually not necessary. Every clinician should be familiar with the process of stopping glucocorticoid therapy. Exceptions include patients who have had adrenal crises and those with prolonged HPA axis suppression from long-term high-dose glucocorticoid therapy. It's recommended that clinicians who implement glucocorticoid therapy educate patients on various endocrine aspects of it. Awareness of potential symptoms can minimize the need for urgent care. These may include hypertension, electrolyte imbalances, and other systemic upsets such as fatigue and nausea. Patients should be educated about the signs of exogenous Cushing syndrome, the risk of adrenal insufficiency, the need for stress dosing with glucocorticoids, and glucocorticoid withdrawal syndrome. Patient education should cover the adverse effects of glucocorticoid therapy, symptoms of withdrawal and adrenal crisis, and how to prevent and treat adrenal crisis. Standardized patient education programs for patients and relatives has proven to be useful in improving knowledge of these aspects. Educational content and delivery should be individualized to each patient. They should include adverse effects of glucocorticoid therapy, symptoms of withdrawal and adrenal crisis, and means to prevent and treat adrenal crisis. Please watch the remaining videos for more information.